A very good morning, guys. So, today I'm happy to join you to have a discussion on thyroid gland anatomy. So, before getting into the session, I would like to thank everyone who gave your valuable comments and suggestions, which helps us to improvise. And we are in the process of improving ourselves with each and every step we are going ahead. And yeah, let's get into the topic. So, today it is going to be about the butterfly gland in the throat. Okay, I mean butterfly gland because it is the butterfly shaped endocrine gland in the throat. So before we get into this class, let us just have a preview of what we are going to see. So that's it. So first we'll begin with what we already know about the thyroid gland, because all of us would have learned the same in our school days, in our higher secondary. So let us just see what we already know. Then we'll get into the topic per se. So first, when we begin, we will be talking about the structure of the gland. So then we will see about the relations of the gland. Then we'll see the arterial and nerve supply. Then we'll see the venous drainage and the lymphatic drainage. And we'll also discuss about the histology of thyroid gland. While discussing about it, I will help you guys to know how exactly we should draw an H&E diagram of the histology of thyroid gland. And yeah, finally, we'll see about embryology. After we finish this off, we'll discuss about the most important part, what to do for your exams, what is important in this particular topic for exams. So actually, this topic is very, very important. Each and every topic, every area in this is important for your exams. Okay, it's an important 10-mark question as well. Right. So guys, come on, let's talk about what we already know about it. So you can see a case in this picture on your screen. So how many of you can identify what it is? Definitely, I'm sure you will be knowing about this before itself. So can you all say what is this condition? And yeah, by the way, today the clinical correlation will be dealt then and there in the topic itself. It will not be dealt separately. So we have some 4 or 5 clinical correlation today. So this will be the first clinical correlation. So can you guys name what you're seeing on the screen? Yeah. Okay. Okay. So you're right. It is goiter. Okay. So we all would have heard very well about goiter. Right. So what is actually goiter? Goiter is the enlargement of the thyroid gland. And this enlargement can be because of 2 reasons. It can be hypothyroidism or even hyperthyroidism. So the one important thing is, to define goiter, we must definitely use the word the pathological enlargement of the thyroid gland. Why? Because the thyroid gland, physiologically, that means normally it enlarges whenever a woman undergoes menstruation or during pregnancy. There is a mild enlargement, but that is not goiter. Okay, that's the reason why we use the term pathological. Okay. So you would also know about the hormones released by the thyroid gland. What are the hormones secreted? So everybody will be knowing it. Thyroxine, and then T3 and calcitonin. Okay. These are the 3 important hormones released. And we also would have heard about hypothyroidism and hyperthyroidism. So I don't think I need to explain it. You will be knowing it. Hypo and hyperthyroidism. Excessive secretion is hyper, and decreased secretion of thyroxine is hypothyroidism. Okay. Now, everybody knows that thyroid gland is an endocrine gland. One additional thing is, this endocrine gland is the only palpable or the superficial endocrine gland. Anybody can do this palpation, right? And that is why the swelling is very prominent externally. So this is the only palpable endocrine gland. Okay. So let's move on to the anatomy. Right. Coming to the structure of the thyroid gland. Okay. All right. So what you see on the screen right now shows the thyroid gland in relation to certain structures around it. Okay. So let me just mark them out for you. So after I describe these structures around the thyroid gland, I'll help you guys to palpate your own thyroid gland. And of course, I want you all to palpate on your own thyroid gland because as I said you before, feel anatomy, learn it in your own body. It will last longer in your memory. So let me first tell you the structures. So first, what you're seeing here is the hyoid bone. Okay. What structure is this? The bone is called as hyoid. Okay. This is hyoid bone. And down below, what you see is called the laryngeal cartilage, right? That is the laryngeal cartilage. Okay. Yeah. Laryngeal cartilage. And below that, what you see, I've marked it there. It is the cricoid cartilage. Yes. So these are three important structures you need to know. And thyroid gland has been marked in the diagram itself, right? The yellow colored one, yellow colored H-shaped or butterfly-shaped structure is the thyroid gland. And the muscle that you see on the side is the sternocleidomastoid. And yeah, below here, what do you see? The two bones here, the manubrium sterni. That is, it's nothing. It's just the sternum or the collar bone. And that particular part you see here is the manubrial part. Okay. And here we have the clavicle. Right. So somebody is asking the greater cornu of hyoid bone. Okay. Greater cornu of hyoid bone, actually you don't need that now, but just because you're asking, I'm telling, greater cornu is this particular part. Okay. Actually, this diagram is not clear for it. It is actually a prominent bony, it is a bony prominence on the hyoid bone. You have greater cornu and lesser cornu, but that is not important for us right now. So let's not talk about it now. Okay. If you want, we'll post the picture about it in the WhatsApp group. Okay. Okay. Now let us see how to palpate or locate our own thyroid gland. Right. So first I said you the uppermost landmark we saw is hyoid bone. So how to palpate your hyoid bone? So when you place your index finger and thumb finger on your throat with a little extension of your head above, you can locate a bone. Okay. When you slightly move the bone to the right and left, I'm telling you again, it is very slightly. Okay. Slightly moving the bone to the right or left. One bone will move, only one bone will move in the neck, and that bone is hyoid bone. Actually, this technique is given in the Cunningham's book. You can refer that once. So that's how you locate the hyoid bone. Okay. Right. The other thing is, in case of males, it is quite easier to palpate or locate the thyroid gland because it is exactly located between the Adam's apple, which is the laryngeal part, and down there you will find the collarbone. So in between the Adam's apple and the collarbone, you can very well locate the thyroid gland. But in case of female, the Adam's apple is not prominent; it is not there. So we need to count the tracheal rings. Okay, so that's how we do. We need to palpate the laryngeal cartilage. Okay, the highly resonating part in the throat when you speak is the laryngeal cartilage. Okay, down the hyoid bone there is a highly resonating region, and below that only the thyroid gland is located, and of course it is above the collarbone. Okay, so this is how we palpate our thyroid gland. Now let us see about the extent of the thyroid gland in the neck. Okay, so what you are seeing right now is a drawing of the same structure which we saw previously. What are you seeing on the top? This is the hyoid bone, right? This is the laryngeal cartilage. The black color is the cricoid cartilage, and below that all the gray rings or plates, these are the these are the tracheal rings. Okay, so one important thing, we need to know the number of the tracheal ring. That's how we actually tell about the extent of the gland. Okay, so first tracheal ring is immediately below cricoid cartilage, and below that second, then third, and then 4, 5, and 6. Okay, up to 6 is enough for us, right? So what is the extent of thyroid gland? Before seeing that, let me show some parts of thyroid gland. Okay, look at here. This is how the gross appearance of thyroid gland will be. So here, this golden part, this is the thyroid gland. Let me mark the parts for you. Okay. So, yeah. So on the top, okay, the topmost region, this is called the apex. This is the apex. Okay. And the bottom is the base. Cool. Okay. So first of all, the thyroid gland has two important regions. One is two lateral lobes on the lateral aspect, and the one which connects the two lateral lobes is called the isthmus of thyroid gland. Okay, so this is our isthmus. The lateral lobes are having the apex and the base, and the isthmus in the middle. Okay. Now, what is the extent of the lateral lobe? First, we'll see that. The extent of lateral lobe, apical extent is up to the oblique line of the thyroid cartilage. On the thyroid cartilage, there is a line called oblique line. It's a marking. That is the maximum extent above. That is the apex extends up to the oblique line of laryngeal cartilage. And below, the base can extend up to 5th or 6th tracheal ring. Okay. So the base extends up to 5th or 6th tracheal ring. All right. And the isthmus, what is the extent of isthmus? Isthmus is extending between the 2nd, 3rd, and the 4th tracheal rings. So these are the 3 tracheal rings over which the isthmus usually lies. Okay, so let me show that in this picture. Let's mark it on the tracheal rings and the laryngeal cartilage. Okay. So come on. What did I say? The apex extends up to the oblique line, which means it is somewhere here. Okay, from there. What is the base extending up to? 5th or 6th cartilage. I mean 5th or 6th tracheal ring. So which means I'm locating it here. Okay. So this is the base. This is where the apex is. Okay. Now where does the isthmus extend between? So it extends between the 2, 3, 4 tracheal rings. So it's somewhere between this. So come on, let's continue. Let's connect the dots, and there we get the diagram. So from the oblique line, I'm coming down. The base is broader, we know that. So then I'm coming and reaching the 2nd tracheal ring where the isthmus starts. I'm going up, and yeah, I'm coming down on the other side. Okay, so here we got the thyroid gland. So this is how it is located. So you just have to memorize the extents, then it will be very easy for you to draw the diagram in exam also, because that's how they actually check for paper in the diagram. All right. So now you know the basic parts of thyroid gland, and you also know the extent. So actually what we saw right now is the anterior extent, right? We talked with respect to the laryngeal cartilage, the tracheal rings. So it is about the anterior aspect of thyroid gland. But on the posterior aspect, because thyroid gland, how it is located? It is located like clasping the trachea, which means it is extending from anterior, goes laterally to the posterior aspect. But completely on the posterior aspect, it is not united. The lateral lobes are united only by the isthmus, and the isthmus is only on the anterior aspect. So we should also know about the posterior extent. So usually the posterior extent is between C5, C6, C7 and T1. Okay, C5, C6, C7, T1. It's up to T1 usually. Now let's see about okay. All right, now let us see about the capsules in the thyroid gland. Okay, capsule is the covering portion of the thyroid gland. So we call thyroid gland as an encapsulated endocrine gland. So the capsule has two parts. Okay, it has a true capsule and a false capsule. True capsule means it is coming from the gland itself. False capsule, it is not originating from the gland, it is somewhere from outside. That's why it is a false capsule. So what is the true capsule exactly? We know that thyroid gland contains the stroma or the connective tissue in which the follicles or the lobules are embedded. So there is a fibrous component, right? So this fibrous component is thickened peripherally. The peripheral condensation of the thyroid matrix, that is the stroma or the fibrous stroma, is called the true capsule. Okay, that's how true capsule is formed. And what is false capsule then? So we said the thyroid gland is located anterior to the trachea. Yes. So in front of the trachea, there is something called pretracheal fascia, right? So pretracheal fascia is present in front of the trachea. This pretracheal fascia undergoes some splitting. Okay. So when it splits, it forms the false capsule of the thyroid gland. Okay, that encloses the thyroid gland completely, and it is called the false capsule. Okay. So yeah. Know one thing, there is a venous plexus here. What is the venous plexus? The thyroid venous plexus is located within the true capsule. Okay. Yeah. The venous plexus is enclosed within the true capsule. You can correlate this with the capsule of the prostate gland, because in prostate gland there is also similar true fascia and false fascia. I mean true capsule and the false capsule, but there the similar venous plexus is present in between the true and the false capsule. Okay, there is a clinical correlation with respect to it, because when we perform the surgery, we must keep in mind that sometimes the vein can be ruptured. If we tend to cut the vein while removing the capsule, it is quite dangerous. So in that case, we need to look into this aspect, because in prostate the surgery is different, in thyroid the surgery is different. Okay, so yeah. And then coming to the next aspect of thyroid gland. Okay, so now we have seen about the structures in the thyroid gland, right? I mean the parts of the thyroid gland, basic parts we have seen. Now we will see about the surfaces and borders in the thyroid gland. Then with respect to that, we will learn about the relations of thyroid gland. So look at here, thyroid gland, we said there are two important parts, the two lateral lobes and there is an isthmus. So first we will see the surface, borders and everything about the lateral lobes. So in the lateral lobes, there are three surface and two borders. So first we will see the surface. I said you the thyroid is clasping the trachea. So let's imagine it's almost like a C shape. Okay, when you see the horizontal cross section, it's like C shape, as you can see in this diagram, right? So from that you can just imagine what could be the probable surfaces. We do not have an anterior surface here. Okay, keep that in mind. We do not have an anterior surface here. What we have here is a medial surface and a lateral surface, and there is a posterior surface. So I'll just show you that in this diagram. Here the purple part is actually the thyroid gland. Yes, the purple one is the thyroid gland. First, let me show the medial surface. Look at here, this is the medial surface. Okay. Then what is the lateral surface? Yeah, so this is the lateral surface. And what is the other surface left out? The one in the posterior aspect, but we call it as posterolateral surface. So these are the three surfaces of thyroid gland. Okay, now there are two borders in the thyroid gland. What could be the two borders? One is an anterior border, the other is a posterior border. So where is the anterior border and posterior border? First we'll see the posterior border. Okay, so the posterior border is located here. I'm marking that for you. Here is a posterior border. So posterior border separates the medial surface from the posterolateral surface. Okay, posterior border separates the medial surface from posterolateral surface. Okay, then what is the anterior border? Anterior border, it can be well appreciated only on the superior aspect of the gland, which means above the level of isthmus. Why is that so? Actually, anterior border is not so prominent. So you can locate that by identifying an artery. What artery is that? The superior thyroid artery. So when you locate the superior thyroid artery, anterior branch specifically, that is the anterior border of the thyroid gland. So these are the borders and surfaces of the lobes of the thyroid gland. Medial, lateral, and posterolateral. Okay. Then two borders are anterior and the posterior border. Okay. Now, what about the isthmus? So, isthmus is having two borders and two surfaces. Okay, for isthmus. For isthmus, there are two borders and two surfaces. What are the two borders? You can say it by yourself. Obviously, there is a superior and an inferior border. Yes. And again, you can tell it by yourself. What could be the two surfaces? What could be the probable two surfaces? Okay, so those are the anterior and the posterior surface. Okay, right. Okay, now let us see the relation. Right. The diagram that is shown in front of you is a cross section. I mean, it's a horizontal section of the neck that is probably at the level of C6 or C7. Okay, so here what do you see? First of all, the purple one is the thyroid gland, as I mentioned you, and those brown color structures, those are the muscles. Okay, the striped ones. And posteriorly here what you see is something called carotid sheath. Okay, this one on both the sides. Okay, then what you see here in the middle, it is the trachea, because we said, right, trachea, over that the thyroid gland is clasped, so you can very well appreciate in this picture. Then behind that what you see, esophagus. Okay, so let us talk in specific the relations. So first, we would first cover the lateral relations in this diagram, the lateral relations of thyroid gland. What are the lateral relations? You can see in the picture. On the lateral aspect, we have three muscles: the sternothyroid, sternohyoid, and omohyoid, specifically the superior belly. Okay, so the name could look complicated, but it is not at all complicated. The name itself implies sternothyroid, so it's extending from the sternum to the thyroid, and sternohyoid, from the sternum to the hyoid bone. Thyroid means thyroid cartilage, and omohyoid. So these are the three muscles. So these are on the lateral aspect. Okay, so that can be seen here, and we can also appreciate well the posterolateral relation, okay, or the posterior relation. So posteriorly, what do you see? You can see the carotid sheath, okay. So carotid sheath, what is it? It is a membrane, okay, membrane or a layer that covers certain structures within it. So what are the structures covered by carotid sheath? The name itself implies it has carotid artery. Okay, so carotid artery is present. And what else could be there? There is an internal jugular vein. Look at, you can see the diagram. There is a common carotid artery, there is internal jugular vein, and there is a nerve which is called vagus nerve. Okay. So these are the three structures covered by the carotid sheath. And there are also two other nervous structures, but they are not the content of the carotid sheath. One is, let me locate it for you. Look at here, I'm marking that in blue color for contrast. Okay, so here in the anterior aspect, we can find a nervous structure called ansa cervicalis. Okay, ansa cervicalis is located on the anterior aspect of the carotid sheath. Okay, it is on the carotid sheath itself, but in the anterior aspect. And here behind, what do you see? That's a sympathetic trunk. So it's not a content of the carotid sheath. It is not present on the margin of the carotid sheath, but it's present outside the carotid sheath on the posterior aspect. So just know it, because carotid sheath can also be a a 2-mark or a 1-mark question for you. Okay, so we have seen the the lateral relations and the posterior relations. So now let us see the medial relations of the thyroid gland. So in this picture, what we can see is only 3 structures can be appreciated here on the medial aspect. One is trachea, the other is esophagus, and you can also see the recurrent laryngeal nerve. But medial aspect, we have about so many structures are there. But to remember the medial relations, you can have a look at this diagram, and always keep in mind the medial relation of the thyroid gland is 2 cartilage, 2 tubes, and 2 muscles, right? 2 cartilage, 2 tubes, and 2 muscles. So what are the 2 cartilages? You already, on the top we saw the thyroid cartilage. Below that we saw the cricoid cartilage. So these are the 2 cartilages. And what are the 2 tubes? Again, you know that, trachea and the esophagus. Okay, the 2 muscles, only about the muscles we have not talked so far. So that's only new for you now. The 2 muscles are, look at the diagram, we have the inferior constrictor muscle. It's here, inferior constrictor muscle. Below that, okay, in the medial aspect, we also have the cricothyroid muscle. So these are the 2 muscles which are on the medial aspect. Okay, so we'll deal about the muscles in detail when we talk about the other structures in the neck. Okay, for now just know the name inferior constrictor and the cricothyroid muscle. Okay, so always when it is medial relation, remember 2 cartilage, 2 tubes, and 2 muscles. So let us have a look at this diagram. This diagram is actually showing us the apex of the thyroid gland, okay, of the lateral lobe. So, okay, so what are we seeing here? This is the apex, the yellow color, okay. All right, and what you see here is the thyroid cartilage. The blue color one, which is longer and on the top, this is the thyroid cartilage, and below that, you know what will come? Cricoid cartilage. Okay, so yeah. Again, look at the muscles here. That is new for you. So previously we said medial aspect. What is the muscle present? It is the inferior constrictor, right? So inferior constrictor has been shown in this diagram. So it is having its attachment between the thyroid cartilage and the cricoid cartilage. So that's inferior constrictor. And over that, we also have the sternothyroid muscle. So this is just to know the relation of the apical part specifically. Okay. So one small recap, what are the relations we have seen so far? We have seen the relations of the lateral lobes of thyroid. What are the relations? We are seeing the the lateral relations, and we saw the posterior, and we saw the medial relations, right? So we saw that laterally or anterolaterally, there are muscles, only muscular. So these are called strap muscles, the sternothyroid, sternohyoid, and omohyoid. So these three are strap muscles. And we also saw the anterior border of the sternocleidomastoid is also forming the relation. Then posterolaterally, or the posterior relationship, was the carotid sheath. The carotid sheath, it had three contents within it: the common carotid artery, the internal jugular vein, and the vagus nerve. Okay, so these three structures were there. And medially, what did we see? Two tubes, two muscles, and two cartilages. Two tubes, esophagus and trachea. Two cartilages, thyroid and cricoid, and the two muscles are inferior. You can see the muscle here, inferior constrictor and the cricothyroid. Okay, so muscles alone you need to keep in memory. Others you can know it now. So till you learn in detail about the muscles, you need to memorize the name of the muscles. Okay, so let us now move on to the arterial and the nerve supply. Okay, so this is an important part, guys. So just have good attention now. Okay, so okay, what you're seeing here is the thyroid gland is in the middle, the same golden color, and here we have some arteries. So what are those arteries? Let us see. Okay, this big arch that you see here, that is the aortic arch. Okay, so that's from where the arteries are arising. So this is the aortic arch. Okay, so this is on the right side and on the left side. That is okay. Let us now see the arteries that supply the thyroid gland. First, let me name them for you, and then I'll show you in the diagram. So first artery, okay, the name itself, okay, it's not a very complicated thing at all. So it is superior thyroid artery, right? And you know what the next one will be. Here. Okay, there's another artery which is, about in 30% of people, this artery is present. So this is called thyroidia ima. Okay, the name is quite peculiar, right? Okay, so this is not found in everyone. It is found only in about 30% of the general population. So first is superior thyroid artery, second inferior, third is thyroidia ima. So let us locate it in the diagram. Superior thyroid artery, from where does it come? See, common carotid artery gives some branches. We have an internal carotid artery, we have external carotid artery. Okay, so right now, say this is the external carotid artery. Okay, so this is our external carotid artery. So this is from where the superior thyroid artery branches out. Okay, the superior thyroid artery branches out and it comes to the apex of the thyroid gland. Okay, as it reaches the apex of the thyroid gland, see, this is just like a story. So it's, you just listen the story. Okay, there's nothing to memorize it and all. You just imagine thyroid gland is there on your neck, or you just imagine somebody else's thyroid gland. Just bring that 3D visual for yourself and think of yourself how this artery is coming. So first, on the lateral aspect, we have the external carotid artery. So from the external carotid artery, the superior thyroid artery is coming. So it's coming and coming and coming, and it's approaching the apex. So as it reaches the apex of the thyroid gland, what happens? It divides into two branches. One is the anterior branch, the other is the posterior branch. So here we have the anterior branch coming forward. Okay. Hope you guys remember one thing which I said you before. When we talked about the anterior border of thyroid gland, I said you anterior border is well appreciated with the help of this artery. That is this artery, anterior branch of superior thyroid artery. Okay, the anterior branch comes anteriorly. Okay, so I could not show you exactly in a three-dimensional view, but just have a look at this. I'm marking it for you. So this is the anterior branch. Okay, and this will be the posterior branch. Okay, so the anterior branch will come down, and the anterior branch of the left side will anastomose with the anterior branch of the right side. Okay, so these form an anastomosis. Okay, just a minute. Yeah, so these form an anastomosis. Anterior branch of left side and right side both will form anastomosis. So what is anastomosis? The arteries are giving branch that interact with, or that has some connections with the other artery which is not having the same origin. Okay, so anastomosis forms here in the middle, right? Then what happens with the posterior branch? Where should it go? Will it anastomose with each other? No, it does not anastomose with each other, but it also anastomoses where means it is anastomosing with the inferior thyroid artery, which is we'll talk about it. So it is anastomosing with inferior thyroid artery. So from where does the inferior thyroid artery come? So have a look at here. From the subclavian artery, there is something called thyrocervical trunk. So from the thyrocervical trunk comes our inferior thyroid artery. Yes. So the inferior thyroid artery is the largest branch of thyrocervical trunk. So this is coming on the inferior aspect. Okay. Again, opposite also, it will come on the inferior aspect. Okay. Probably that might give some minor branches, but the main thing is as it reaches upwards, it is anastomosing with the posterior branch, right? As we told before. Okay. So this is about the arterial supply, guys. This is the most important arterial supply. We already, and yeah, we have left one artery. Thyroidea ima artery. So where is thyroidea ima artery? So it is actually coming on the inferior aspect. From where does it come? Mostly it will be coming from the brachiocephalic trunk. Okay. So these arterial structures and all, about the aortic arch and the carotid arteries, a separate session will be there. So for now, just know the names. So again, when you learn about these arteries, you can correlate it. So mostly it will be coming from the brachiocephalic trunk, okay, like this, and it goes to the inferior aspect, and it enters the thyroid gland on the inferior aspect of isthmus. Okay, so sometimes, rarely, this can also come from the arch of aorta, like this, okay, and it can enter the inferior aspect of the isthmus of thyroid gland. All right, so the arterial supply is over, guys. Okay, now we'll see the nervous supply in the same diagram. Nervous supply. Okay, so this has very important clinical correlation, the nervous supply and the arterial supply. So observe keenly. I have a question for you at the end of this. Okay, so nervous supply. The nerve supplying the thyroid gland, it is from both the sympathetic branch. It has a sympathetic branch and also a parasympathetic branch. So sympathetic branch, it is mainly coming from the superior, middle, and the inferior cervical trunk. Okay, cervical trunk, that is the sympathetic supply. And adilium, specifically, we have the middle cervical trunk. Okay, but all three will be supplying. Okay, important one is middle cervical. All right, and the other one, the parasympathetic. Which one is supplying the parasympathetic? Okay, so there are two nerves. Okay, one is vagus nerve. Remember, vagus is the 10th cranial nerve. Okay, just know it. And the other one is recurrent laryngeal nerve. Okay, right. So here, of all, the recurrent laryngeal nerve is the most important nerve here clinically. Okay, so first we'll see where the nerve is coming. First, a recurrent laryngeal nerve, it comes from the inferior aspect. Okay, so why is the name recurrent laryngeal nerve? Because see, this term applies for artery as well as for the nerves. Okay, so whenever there is a course, there is a normal course, right? Like something goes from above downwards, then it should go above downwards. If it gives a branch, it should give a branch, then it should go downwards, again give a branch, and then it should go downward. But some nerves, some vessels, what they do is the natural course is going, but somewhere at some point they will give a branch which will take a U-turn and get back to the course. That is, it'll make a reverse direction. So that those nerves and vessels are termed recurrent. Okay, before their name, recurrent will be added. So here it is recurrent laryngeal nerve. Mostly these recurrent are found around some joints. Okay, so here we have the recurrent laryngeal nerve. Okay, let me show that on the right side. So the recurrent laryngeal nerve, the course is not definite, so it can vary in many cases. So generally, it is like this. Okay, I think it's difficult to differentiate the color here, so I'm making it to green, but the coding for nerve is always yellow because you will not be able to differentiate it here. I'm making it to green. Okay. Okay. This U should be very prominent, right? Okay. So look at here, the recurrent laryngeal nerve is making that U-turn and then it's going back. So it is mainly supplying the laryngeal cartilage. Okay. So when it is going there, it goes very close to the thyroid gland and supplies the thyroid gland with some branches here. But the most important thing is you need to know that the recurrent laryngeal nerve is coursing along with inferior thyroid artery. Okay, listen carefully. The recurrent laryngeal nerve is coursing along with the inferior thyroid artery. At certain places, it is close to the artery. At certain places, it is away from the artery. What is important? We need to know where it is close to the artery, where it is away from the artery. Okay. So where is it close to the artery? We know that it is close to the artery. From the diagram, it is obvious. It is close to the artery at the apex, all right? So it's close to the artery at the apex. It's away from the artery, probably away from the gland. Okay, so just know this. It's an important factor. Before going to the question, I would like to say another nerve is there, which is having a similar course on the superior aspect. Again, I'm using blue color for the nerve. Okay, so like how the recurrent laryngeal nerve was coursing along with the inferior thyroid artery, on the superior aspect, there's one nerve which is coursing along with the superior thyroid artery, and that nerve is called external laryngeal nerve. Okay, external laryngeal nerve. So external laryngeal nerve is a branch of the superior laryngeal nerve. Okay, external laryngeal nerve branching out from the superior laryngeal nerve is coming down, 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 and it is almost very close to the superior thyroid artery, and as it comes close to the gland, it goes away. Okay, right? It goes away. Actually, the coursing should be on the opposite side. Okay. As it comes close to the gland, okay. So it's coursing closer, but as it reaches near the gland, it goes away. Okay. Right. So here the here the the external laryngeal nerve is close to the superior thyroid artery, away from the gland, and it is close to the artery. Yeah, it is close to the artery, away from the gland, and it is away from the artery, close to the gland. Okay, let us not confuse it. Just remember the diagram. If you know one relation, the opposite is for the other. So just remember the recurrent laryngeal nerve and the inferior thyroid artery. The recurrent laryngeal nerve is close to the artery, that is inferior thyroid artery, when it reaches close to the gland. Okay, just remember this one statement. Recurrent laryngeal nerve is very close to the artery when it is close to the gland. Okay, just remember this. So obviously when it is close to the gland அப்படினா அங்க இருக்கிற relationship will be opposite to the distant one. Okay, so அதே மாதிரி on the superior aspect we have external laryngeal nerve. So this external laryngeal nerve is having an opposite relationship with the superior thyroid artery. Okay, so clinically I said there is an importance for this. So let me tell for the external laryngeal artery, then you will tell me for the recurrent laryngeal artery. So external laryngeal artery, as we mentioned, it is close to the superior thyroid artery, where distant to the gland. Okay, so now when we perform thyroidectomy, okay, it's a surgery where the thyroid gland is removed. So when we want to remove a gland, first of all we will ligate all the arteries that supplying the gland. So ligation means we are cutting the supply. So when we ligate, sometimes accidentally, if we ligate the artery close to the nerve, there are chances we may cut the nerve. So for that reason, when I want to ligate the superior thyroid artery, I will not ligate it distant from the gland. Okay, so much, so I will not ligate it at the point of origin. I will try to ligate it close to the gland. Why? Because that's how we can protect the nerve from getting injured, because the nerve is away from the artery, close to the gland. Okay, so I hope you understand. We want to ligate only the artery, we don't want to cut the nerve. Okay, so to prevent the injury to the nerve, we are ligating the artery close to the gland. Which artery? Superior thyroid artery. Now you will tell me, for recurrent laryngeal nerve and inferior thyroid artery, I want to ligate the inferior thyroid artery. Which area, that is, where should I ligate the artery, inferior thyroid artery, so that I would not injure the recurrent laryngeal nerve? Is it close to the gland or away from the gland? Where should I ligate? Okay, can you tell? Yeah, very good. So everybody has understood. Away from the gland or distant from the gland? Right. So that is the important clinical correlation here. So this is one thing which you should always have in your mind, because such questions will be repeatedly asked to you when you go to postings, when you go to your final year. All the time, this is a common question which is asked. Okay. Now that is about the arterial and the nerve supply. Coming to the venous and the lymphatic drainage. Okay. So venous lymphatic drainage. Like how we mentioned the arteries first, I will name the veins for you. Then we will see it in the diagram. So how many veins do we have here that drains the thyroid gland? So basically there are three important veins. Okay. So it's not like superior thyroid artery and inferior thyroid artery. Just adu mattum illa. We are also having superior thyroid, inferior thyroid. That we also have middle thyroid. Okay. So first, superior thyroid vein. Then we have middle thyroid vein, and the third one is the inferior thyroid vein. Okay. There's an additional vein, like how we saw an additional artery, thyroidia ima. Here there is an additional vein, which is also a rarer one, called Kocher's vein. Okay. Okay, which artery is usually ligated? Actually, see, when we are performing thyroidectomy, after completing this venous and the lymphatic drainage, I'll elaborate about the thyroidectomy. So by the time I'll tell you. Wait, so first we'll do these veins. Okay, so we are having superior thyroid, middle thyroid vein, and inferior thyroid vein and Kocher's vein. So what we need to know is, how is it draining? So first look at here in the diagram. Here's our superior thyroid vein. So here's the superior thyroid vein, and here's my middle thyroid vein. So both of these are draining into the internal jugular vein. Okay, so superior thyroid vein, middle thyroid vein, both are coming and draining into the IJV, internal jugular vein. And there is inferior thyroid vein. So inferior thyroid vein, where does it drain? So see, inferior thyroid vein is present on the inferior aspect of the isthmus of thyroid gland. So here is it. Okay, so it is draining into the brachiocephalic vein. Okay, so especially the left brachiocephalic vein. Right. So that's an important thing you need to know. Superior and middle are draining into the IJV. Superior middle drains into the IJV. So guys, if you know the diagram, then there is nothing to memorize. So if you know the diagram, you can write everything by yourself. Okay. So inferior is draining into the left brachiocephalic vein. Okay, the left brachiocephalic vein. And if there is a Kocher's vein, that will also have a course, and it is the Kocher's vein drains from the inferior lobe of the thyroid gland. Okay. Now coming to the lymphatic drainage. Okay, so lymphatic drainage, we are dividing them into two groups, the superior group of lymph nodes and the inferior group of lymph nodes. The superior group of lymph nodes includes the pre-laryngeal and the superior cervical, superior deep cervical. Okay, pre-laryngeal and the superior deep cervical. The inferior group will include the pretracheal. So as you can see in the diagram, based on the location only, they name that way. So why are these lymph nodes very important? The lymph nodes are important because sometimes when there is a tumor in the thyroid gland, we should know whether the tumor has been infiltrated into the lymph nodes. So for that, we should know where the lymph nodes are located so that we can find out whether the infiltration has happened or not. Sometimes the swelling in the neck could not be because of the thyroid enlargement. It could also be because of the lymph node enlargement. Okay. So that's another clinically important thing we should keep in mind. Right. Now I would like to talk something about the thyroidectomy. Okay, so this is also an important clinical correlation here. Thyroidectomy is a surgery which is performed to excise the thyroid gland. Why do we excise thyroid gland? We excise it because it is having a tumor which cannot be treated, right? So in those cases, we excise the thyroid. Sometimes when the goiter is uncompensated, even so, these are some common causes why thyroidectomy is performed. So thyroidectomy has some types. So first type is total thyroidectomy. Okay, so the entire gland will be removed, all the lobes, isthmus, everything. And second is called hemithyroidectomy. Only half of the gland is removed. The pathological side will be removed and the normal side will be left. So that is hemithyroidectomy. And the third type is called near total thyroidectomy. What is near total? Near total means it is not totally removed, but most region of the gland, most part has been removed. So only a little part is left. Why is it left? Commonly, this is because of preservation of the parathyroid glands. So what are parathyroid glands? These are also endocrine glands. So these are actually present on the posterior aspect of the thyroid gland. Okay, so these are secreting the parathormone, which will have the main function of increasing the calcium level in the blood. So the parathormone is released by the thyroid gland. Okay, so okay, the parathyroid gland is located on the posterior aspect. So if we are excising the thyroid gland, what will happen? We will remove the parathyroid also, because parathyroid is found attached to the thyroid gland. So what happens when you remove the parathyroid also? There is no parathormone now. Now, when there is no parathormone, the calcium level will not be reaching the normal state in the blood. So it will go down, down, down. So that will cause another disease. Okay. So for that reason, surgeons do not take off the entire thyroid gland. So that is why near total thyroidectomy is practiced. That is the commonly performed thyroidectomy, in which we spare the parathyroid. Okay, we spare the parathyroid and we will remove only the thyroid gland. Okay, we will remove it almost, leaving the parathyroid. So that is about the thyroidectomy. So when the thyroidectomy is performed, based on which area we are taking off, we put incisions and take off the gland. But as somebody has asked about which artery to ligate commonly, there's nothing like that. We would usually ligate both the superior and inferior thyroid arteries, because they have anastomosis. So if you ligate only the one artery, no use. That's of no use. So you need to ligate both the arteries. The level is important. Okay. The reason is, I forgot to tell you there, the recurrent laryngeal nerve, if you cut that accidentally, what will happen? The recurrent laryngeal nerve, as I mentioned you, it supplies the larynx. Larynx is the voice box. Without a voice box, we cannot talk, right? So if I accidentally cut the laryngeal nerve, the recurrent laryngeal nerve on the right side of the patient or the left side, but only on one side, what happens? The voice will become hoarse, which means it will become rough. Okay, the voice will become rough and it will be difficult for the person to speak. Sometimes it can also cause temporary aphonia. What is aphonia? Aphonia is there is no sound, phonic sound. You will not have a voice. That will be temporary aphonia. But if we cut off both the laryngeal nerve, recurrent laryngeal nerve, definitely the voice will be gone. So this is a very crucial surgery, right? Okay, now let us move on to histology. Okay. Okay, so right. So what you see in the screen right now is the histology of thyroid gland. The left side is the picture drawn in a paper. I took it from a record notebook. Okay. So this is how the thyroid histology looks like. So before talking about the features of this histological appearance, first let us see how the histological diagram is made. How do we create this? So there is thyroid gland. We are excising it. Surgery is done. They are taking the thyroid and giving it to the pathology lab to process the gland and see for the histology. Okay. One is, there will be two cases where this histology is performed. One is in a diagnostic point of view, as a biopsy. Biopsy can be done. Okay. The other one is after excising the entire thyroid gland, it will be sent to the lab to look for the histological report. Okay. So these are two common cases where the thyroid gland is seen in under histology, under microscope. So first, let us say somebody has excised and given the gland to the pathology. Now what they will do is they will cut off the gland. Okay, so they will cut the gland, take sections of it, and then they will view it under the microscope. So for now, as we are learning the normal histology, right? We are learning the normal histology. Normally, just remember this way: we have a gland, right? It is a lobulated gland. So it's a lobulated gland and it has lots of follicles. So what is the actual shape of follicle? Follicles are spherical in shape, okay? Follicles are spherical in shape. But when we take a cross section or a cut section, that becomes like what it looks in the picture now, okay? Yeah. So here I've marked it, the follicular cells and the follicle with colloid. Colloid is actually a material within the follicle, okay? So when you take a cross section or cut section, this becomes a structure with different shapes, but basically the follicles are spherical in shape, okay? Now let us describe the parts of this histology, right? So what are you seeing here? Right. So look at here. There are so many similar structures with cells lining on the inner aspect. Those are called the follicles. So this is a follicle. So what is a follicle made of? The follicle is lined by cuboidal epithelium. Usually it is a cuboidal epithelium because glands are usually lined by cuboidal epithelium. Okay. And sometimes when the gland is atrophied, okay, sometimes when the gland is atrophied, the cells become flattened. Okay, the cells become flattened. And when the gland is hyperactive, that is overactive, what happens? The gland cells, those lining cells which were cuboidal, become kind of columnar. Okay, so it's based on the activity how the cells look like. But generally, normal thyroid gland, the section will show the follicles with cuboidal epithelium. So I hope you guys know what is cuboidal epithelium. The epithelial cells where the height and that is the length and the breadth are the same. Okay, the height and the width are the same. Okay, so what is present within this follicle? So the follicle, each follicle contains something called colloid. What is a colloid? So what you see here right now, I'm highlighting it. This is colloid. Okay. So what is a colloid? Colloid is a storage material. Okay. So colloid is a storage material which is storing the secretions of the thyroid gland. Okay, colloid stores the secretions of thyroid gland. It is a gelatinous material. It usually stains pale pink in color. And the other structure which you can appreciate is this one, the connective tissue. So there are two connective tissues here. What are the two connective tissues? Interlobular connective tissue and the interfollicular. Interfollicular means in between the follicles. Okay, so there are two connective tissues, interlobular and interfollicular. Okay, and this is where you can commonly find the arterioles and venules. Now coming to parafollicular cells. So parafollicular cells are existing as single or cluster of cells in between the follicles, that is in the interfollicular area. So I've marked it here. These are the parafollicular cells. Okay, so what is the function of a parafollicular cell? The other name for parafollicular cell is C cell. That tells us about the function. It is called C cell because it secretes calcitonin. Okay, calcitonin is a hormone that decreases the calcium level in the blood. Okay, so on the right side, I just want to show you how to draw a follicle. I'll just show you one follicle. So that's how you will draw the other follicles too. Okay. So follicle can be of any shape, as I said you. Basically, it is spherical, but on cross section, it will take up many shapes. And make sure whenever you draw your histology diagram, the pencil should be sharp. And this is how the cuboidal cells will be. Okay. So within that, we have the colloid. So colloid is little less pink in color, that is, it is paler in color. Okay. And don't forget to put the nucleus. Okay. So that's how you draw a follicle. In a cuboidal cell, the nucleus will be round in shape and is mostly located at the center of the cell. Okay. All right. So that's about the histology. Now we'll see about the embryology of thyroid gland. Okay. So talking about the embryology, see, this is a very interesting one. Okay. Embryology of thyroid gland is a very interesting topic. The thyroid gland, it's like a story. Okay, you have to imagine it for yourself. Then I will show you a video about it, an animation on the development of thyroid gland. So first, just listen to me. The thyroid gland, it is first formed on the floor of the embryonic pharynx. So floor of embryonic pharynx has a structure called foramen cecum on the midline. Okay, so just imagine as I tell you, then I will show you the animation. On the floor of the embryonic pharynx at the midline, there is foramen cecum. That's from where, that is the point from where the thyroid gland starts developing. So what happens? The thyroid gland initially, it starts developing at the 3rd week of intrauterine life. Okay, it starts from the 3rd week and ends in the 7th week. So it starts in the 3rd week, and the thyroid gland initially, it's not the gland at all. There is only one point. The point will undergo endodermal thickening. Okay, endodermal thickening. So this thickening will gently go down. Okay, so it will go down and form a duct. What is that duct called? Is thyroglossal duct. Okay, the thyroglossal duct goes down, 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 and by 7th week, it will reach the exact location where it should be in an adult. Okay, so it's coming down and it's reaching the location. So while it is coming down, what happens? The terminal part of the thyroglossal duct, the thyroglossal duct at the terminal part will bifurcate. What is bifurcating? It divides into 2 branches in the middle. So the bifurcation will then elaborate further, and that forms the lateral lobes of the thyroid gland. Okay, so now we have the lateral lobe of the thyroid gland. So now I'll just show you how this is actually formed. Okay, now just have a look at this video, guys. So this is an animation on how the thyroid gland develops. Actually, I'll just tell you what are all the structures here. So this dark pink color or the pale brown colored structure on the 2 lateral aspects, this is where we have the pharyngeal arches and pharyngeal pouches and pharyngeal grooves. So these terms are new to you, so this will be taken as a separate class, but just know the terms now. So here in the midline, I said you the embryonic pharynx has on the midline an opening called foramen cecum, right? So the foramen cecum, it is here. I mean, the green color is the floor of the pharyngeal pouch. I mean, floor of the pharynx. So the floor of the pharynx is where the foramen cecum is present. So this center is this foramen cecum, and down there the thyroid gland is going to develop. So if you can see here, the white colored one is the endodermal thickening, and this endodermal thickening is now going to come down. Okay, the white color is the endodermal thickening. The endodermal thickening will gradually come down. It will form a depression called the Thyroglossal Duct. The duct is going down. As it goes down, it bifurcates. Now you can see that there is a somewhat U-shaped structure. So as it goes down, it enlarges, and as it goes down, it is enlarging, and yeah, as you saw there, that's how the thyroid gland is formed. Okay, as it goes down, I want to mention here, there are certain structures which are getting inside the parenchyma of the thyroid gland. So one important structure is called the ultimobranchial body. This is a new term for you, ultimobranchial body. What is ultimobranchial body? It is coming from the fifth pharyngeal pouch. Okay, so what is ultimobranchial body going to do in the thyroid gland? This is what is going to form the C cells or the parafollicular cells that we mentioned. Okay, so the C cells are formed from the ultimobranchial body. Okay, so just for once, you can watch the video again. And by this time, I would like to thank my friend Gokul Vasant, who actually created this wonderful animation for the embryology of thyroid gland. Okay. All right. Okay. Now back to this picture. So in this, there is an important embryology clinical correlation to be discussed. So what is it? Now just have a look at this diagram. We'll see the course slightly. Okay, starting from the foramen cecum at the floor of the embryonic pharynx, the endodermal thickening occurs and thyroglossal duct. As I'm showing you, it comes down, down, and as it comes near the hyoid bone, it is initially on the anterior aspect, and then it goes little posteriorly to go retrohyoid. What is retrohyoid? Posterior. Retro means posterior, and then again it comes to the anterior aspect. So then it is coming to the front of the thyroid cartilage, and then it comes down to reach the thyroid gland. Okay. So the clinical correlation here is, sometimes, naturally what happens after the thyroglossal duct does its function of leaving the thyroid gland in the location. What happens sometimes, wait, yeah, okay. Normally, what happens? The thyroglossal duct will take the thyroid gland, it goes and drops it in the location where it should be, and then the thyroglossal duct will disappear. Just like that, it will disappear. But sometimes what happens is, the thyroglossal duct does not disappear. So it's not normal, right? So the thyroglossal duct does not disappear, and what it will form is something called thyroglossal cyst. Okay, if it does not disappear and if it persists in the fetus, and as the child comes out after the baby is born, still the thyroglossal duct is there, we call it thyroglossal cyst. Okay, so that is one thing. Another thing is, the thyroid gland is not to be present in the exact location where which we discussed in the extent, right? Sometimes, rarely, there can be ectopic thyroid gland, and sometimes there can be aberrant thyroid gland. What is ectopic thyroid gland? When the thyroid gland is coming along its course, sometimes it might not reach till the location where it is actually existing in adults. Sometimes it might stop near the hyoid bone. Sometimes it might stop near the thyroid cartilage. Sometimes it might even stop. It might not even move from the where the foramen cecum. Okay, so when such a thing happens, we call those glands as ectopic thyroid gland. Ectopic means outside, somewhere outside, which is not normal. So based on the location, we name them like if it is near the foramen cecum, we call it lingual thyroid. If it is around the hyoid bone, it can be superior, inferior, or the retrohyoid. Okay. So based on the location, we have different types of ectopic thyroid. Sometimes, thyroid gland can be called as aberrant thyroid gland. Why aberrant? The thyroid gland is normally present, but additionally, there is some additional thyroid tissue present somewhere else. So such a thyroid tissue is termed as the aberrant thyroid gland. Okay. Now that's about the embryology. And now, finally, we'll see what is important for the exams. Okay. So that's what everybody will be curious about, actually. So the entire topic that we discussed today is an important 10 mark. Everything will be asked. The arterial supply, nerve supply, venous, lymphatic drainage, the borders, surfaces of the gland, histology, embryology, everything could be asked as a 10 mark on the whole. And of course, that's a repeated question. Then short notes, repeatedly, there are blood supply of thyroid gland. The embryology is also asked frequently. Thyroglossal duct is also a short note. So we need to describe about how the thyroglossal duct is formed. What are all the anomalies which are occurring when the thyroglossal duct is not performing normally its function. So we need to write about the thyroglossal cyst. We need to write about the ectopic thyroid and all. Then surface and borders of thyroid. So it should be discussed in two ways. One is about the lobes, the lateral lobes with respect to them, and then it is about the isthmus of thyroid gland. And sometimes it can be bluntly asked as thyroid. So you should write precisely every topic if it is asked in a short note. Then one important 1 mark is recurrent laryngeal nerve. As what we discussed, they might ask this one: where should the inferior inferior thyroid artery to be ligated, and where should be the superior thyroid artery? Inferior thyroid artery, remember, always away from the gland. Superior thyroid artery always close to the gland. So that's an important 1 mark. Okay, guys, so that's about the thyroid gland. So hope you understood everything. And if you have any doubts, you can ask in the comments section, or you can ask in the WhatsApp group. So here we ended the session. Thank you.